Hello everyone. Happy New Year 2022. My name is Dr. Padmanabhan. I'm a vascular surgeon, but I've been telling you, I've been doing a series of lectures on diseases of importance in old people. Basically I concentrate on diseases of old people in India because that's the people I interact with as a vascular surgeon most of the time. I've done two series, one on disease of central nervous system and another one on cardiovascular system. So I was planning to do another one on like kidney diseases, but I started reading it. It's actually two, three books, short books on nephrology and all those things, and I got nowhere. So I thought I'd make a small video in between on gastrointestinal disease in old age. So GI tract is divided into upper GI tract, lower GI tract generally. So I'll be covering the upper GI tract today. And upper GI tract starts from the mouth to the end of the stomach. That's called the duodenum. So from the mouth it goes to the pharynx, what's called pharynx, and then it goes to the pharynx, otherwise called gullet or throat. And then but a throat actually can also mean part of the esophagus also. Esophagus is the part to which pharynx communicates. Pharynx is a large space, open space. It has a dimension from the bottom of the cranium, that is the in the base of the brain, to the esophagus. Esophagus is opening. It is that huge. It's about 10 centimeters this wide also. So that is pharynx. So it's divided into nasopharynx just behind our nose and oropharynx behind the mouth. So the mouth itself is the anterior part of the pharynx. It's called mouth, buccal in medical terminology. So my disease of the mouth in our old age is, mouth is the part where you chew the food, and then it's taken to the pharynx to be transported to esophagus down to the stomach. So in the mouth itself, the masticatory muscles will lose considerable bulk by the time you reach 70 years. So the mastication becomes a problem. Another thing is the mandibular bone has resorption. So the teeth will start falling out, the straight teeth will start widening. And sometimes even if you have dentures there, dentures means instead of tooth, you have artificial tooth. That cannot even hold there. So that's a problem in old age. So that leads to leads to that wasting in geriatric wasting, or geriatric what's called the thing geriatric debility. There's another word for it, I forgot it. So the mouth has another function also. The mouth, the feel the taste of the food in the mouth. That is because of there are what's called taste buds, mainly on it's all over the oral mucosa, but taste buds are mainly concentrated on the tongue, and that will get depleted by 60, 70 years. So that your taste may not be as good as in younger days. And then compounding that problem is the sense of smell will also go down drastically when you become 70 years. By 70 years, more than 50% of the sensation of, or the acuity of sense, the smell will go. When once the smell goes down, what happens is the taste also comes down proportionately. So these all lead to nutritional deficiency in old age. That's one thing. So the problems in the mouth are what's called. I'm not talking about. See, this is an area of specialization of ENT and all those people, And most of the things in this pharynx, esophagus, mouth, stomach is done by diagnosis done by a process called endoscopy. Endoscopy means you put a tube with camera on it and a light on it into the mouth, into the pharynx, into the esophagus, into the stomach, go down in the stomach and look at it, make diagnosis, not like before, not from the symptoms only. You can specifically see what's happening, pathology, what's happening there, take biopsies from there. But these are done by specialists. But I am talking generally about people, like us who take care of old people, but who are not specialists in this field. So in the mouth itself, it's the common problem in the old age is called what's called stomatitis. Stoma means mouth. Stomatitis means inflammation in the mouth. This happens because of some immunology, generally because of immunology problem. If somebody has some decreased immunity, the cells on the cells on the surface of it's all squamous epithelium, and gets desquamates more. So it becomes like raw surface. It becomes a raw surface, raw surface, and that's called stomatitis. Stomatitis. That's it's the main problem in old age, and people having reduced immunity. What happens is that after that the superinfection takes place, bacteria takes over, and also fungal infection will come. The most common fungus is called Candida. So Candida infection comes. And another problem is that sometimes what's called a hairy tongue. The tongue, usually on the tongue, there is a cycle of the cells are shed and then new cells are formed on the tongue. But sometimes the shed cells will stay there, and bacteria will invade that place and produce a black color. That's called black hairy tongue. It's not an infection. Mainly it is because of the desquamated squamous cells or the cells of the tongue remaining there and getting infected. So the main thing is you remove it nicely, and some oral wash. You can dilute hydrogen peroxide wash. That's the main thing. But these are the general things in old age. But the people in old age also have difficulty swallowing. It's called the difficulty. The swallowing in medical term is deglutition. From glottis, glutition means from the tongue it comes down. Goes to the from the pharynx to the esophagus. That process called deglutition. Swallowing. It's a swallowing. The swallowing actually takes place by the movement of the tongue first. That's called it's a movement called peristalsis throughout the gastrointestinal tract. It's called peristalsis. It's a small like a rotation, like a movement, like a small movement which will move the the food or the intestinal contents forward. It's called peristalsis. But starts at the root of the tongue. But it's not that. It's not only the peristalsis which moves the food. Actually, the muscles of the tongue and the muscles of the pharynx has to act. Then it has to contract actually. Then the relaxation of the upper esophageal muscle has to take place. That's called there is a muscle which guards that opening into the esophagus. Esophagus is the second part. From the pharynx goes to the esophagus. So it's called cricopharyngeus muscle. That has to take. So it's a synergistic movement, contraction and relaxation. So when there is a derangement in that, it can produce what's called dysphagia or difficulty swallowing. It's sometimes called achalasia when the sphincter, that cricopharyngeal, muscle relaxation. The relaxation is the only problem. Means Cricopharyngeal muscle is not relaxing, it's called achalasia, cricopharyngeal achalasia. So these are the two problems. One is this one pharyngeal dysphagia because of the muscles of the pharynx are not contracting properly. Most of the time it is not contracting because there is something called bulbar paralysis. Bulb means here refers to the lower part of the brain called medulla. Because from medulla comes all the nerves supplying the pharynx. That is, all the lower 5 nerves are there, like facial, glossopharyngeal, vagus, accessory, and the hypoglossal. These are the names of the lower cranial nerves. These are called cranial nerves. Cranial nerves, it supplies all the part of the thing, cranium. The upper cranial nerves supply the nose, the structures from which goes to this is not a detail on all those things. It's just a talk on upper GI problems. But I'm just going in for your interest. There are the upper cranial nerve supply the eyes, nose, that is the smell function, the ocular function, as well as our movement of the muscles of the face function. It's called trigeminal nerves. Then the extraocular means the external, the muscle, the eye has to move, eye has to see, eye has to move also. The movement of the eye movement muscles also. These are upper cranial nerves. Lower cranial nerves mainly supply the swallowing muscles, the pharyngeal muscles. So if the most common cause is bulbar paralysis because of cerebrovascular accidents, things like that. And also people have diabetes. Diabetic neuropathy is there. When you have diabetes for a long time, it affects the nerves. It's called diabetic neuropathy. That also will produce difficulty in swallowing. So these are two things. Then cricopharyngeal achalasia means the cricopharyngeal muscle is going into a spasm. It's not relaxing properly. That itself can cause dysphagia. And for the treatment for this condition is, it's usually seen in people have just had a stroke. But even such people, the cricopharynx is not relaxing. So what you can do is do a otomy or cutting of the cricopharyngeal muscle. It's called cricopharyngeotomy. Cricopharyngeal muscle. Muscle section by usually using laser nowadays. By endoscopically, putting the endoscope into the mouth, throwing this one laser or some source of energy which will cut the muscle without much bleeding, and it usually gives good result. Then esophageal abnormal, the food from the oropharynx, the food then has to, let's say the food goes to the esophagus, then it has to come down. For come down, esophageal peristalsis has to be there. It has to move like that. So again, esophageal muscles have to move in a coordinated fashion. The upper esophagus has to relax. Then when the food comes down, lower esophagus to relax. There is a part called the cardia, near the cardia. That is the stomach. Cardia means it's actually towards near the heart. That's why maybe it's called cardia. So that is a junction is there. Between the junction between the stomach and the esophagus, there is a sphincter. That is to relax. The food, if the food has to go to the stomach. So it's a movement of the movement because of the contraction of the muscles of the esophagus. So that has been orderly fashion. Several disorders happen in old people. It's called motility disorders of the esophagus. Motility disorders. So what happens is, in old age they have what's called spasm. So the esophageal spasm will produce hold up of the food. It will not go down. It causes dysphagia. Again, this just as oropharyngeal dysphagia, this is called esophageal dysphagia. So food will not go down. So it can be two types. One is called diffuse esophageal spasm. Esophageal muscle goes into spasm for some time, diffusely. So there will be intermittent. Intermittent means from time to time. Dysphagia, not all the time. But there is another more severe. It's called nutcracker esophagus. It is actually this one. The spasm is prolonged duration, and so it leads to dysphagia of a lot of dysphagia. It can also lead to all this spasm. Esophageal spasm can lead to pain or chest pain. You have to differentiate from the cardiac pain. Sometimes it can be one cause of chest pain. It's diffuse esophageal spasm. Nutcracker esophagus can be a cause for chest pain in old people. Then Then the other things in dysphagia in the stomach in the esophagus can be, it's called what's called aortic dysphagia, specifically in old people, aortic dysphagia, because the arch of the aorta, the aorta comes from the heart, then it arches upwards, then goes down at the back of the neck. That is called arch of the aorta. The arch of the aorta can press on if there is a aortic aneurysm. The aneurysm is dilatation of that part of the aorta. Aorta means the largest blood vessel in the body. It can press on the esophagus, produce what is called aortic dysphagia. Even without this thing, that usually happens in the upper part of the esophagus. It's an dysphagia or difficulty in swallowing in the upper part of the esophagus. But the lower part of the esophagus also, sometimes there is what's called the damage in the aorta, called atherosclerotic, age-related damage. It can actually impact on the lower part of the esophagus, press it between the heart and the aorta, produce some amount of dysphagia. That's called aortic dysphagia. And then you can have diverticula in the esophagus, but diverticular disease is not that common in the esophagus. It's more common in other parts of the GI tract like colon and all those places. But you can have diverticula also, which can lead to this dysphagia problem. And other problem is what's called esophagitis. Just like stomatitis, you can have esophagitis. The cause for esophagitis usually is what's called reflux. The stomach has a lot of acid in it, and the stomach is divided from the, protected from the esophagus is protected from the stomach acid by the sphincter. Sometimes the sphincter can become a little non-functional, and so the acid can reflect upwards. The lower is actually the esophageal junction is somewhere here in the epigastrium. Epigastrium means here, just at below the sternum. But generally that sensation will be felt behind the sternum. So it's called pyrosis, or it's called heartburn. The common term is called heartburn, because heart is there. It's a heartburn. It's like so it's also different diagnosis for cardiac pain. So this heartburn can cause esophagitis, and not only esophagitis. The heartburn prolongs, stays there for a long time. What happens is the esophageal mucosal cells get what's called metaplasia. Metaplasia, it changes. It changes its color, and not color. It changes its quality or its structure. Actually, it's made up of the square cells called squamous cells. Squamous cells. Then the squamous cell can become columnar. The columnar cells are in the other parts of the GI tract. It produces what's called the Barrett's esophagus. Barrett's, I'm not sure whether it's a person or something else. Barrett, probably is a physician or a surgeon or somebody. Barrett's esophagus, it's called Barrett's esophagus. Why it's important is Barrett's esophagus is a precursor for malignancy in the esophagus. Malignancy is a very common in the esophagus. I mean, it is the most important problem in the esophagus. So Barrett's esophagus is one of the precursors of this one malignancy. Others being problems like this one the achalasia. I told you about achalasia in the cricopharynx. The same process can take place at the gastroesophageal junction. It's called achalasia of the this one esophagus. And achalasia means actually achalasia means not relaxing. Achalasia means relaxing, not relaxing. It's not relaxing. It can be actually because of some muscular contraction in young age, but in old age generally achalasia is caused by by malignancy by two processes. One is if there is a malignancy right there, like gastroesophageal junction, can produce achalasia. The food will not go down. Achalasia means it's not allowing the relaxation of that sphincter. Another thing is by a paraneoplastic effect. Even if the tumor is not there, like pancreatic tumor or the tumor of the lungs or bronchus called oat cell tumor. In fact, oat cell tumor is the most common cause of achalasia cardia in achalasia of this sphincter in old age. Oat cell tumor of the bronchus by paraneoplastic. So in old age, don't think that you can just get away with doing some surgery there. You always have to take a biopsy, rule out malignancy. That treatment again is like cricothyrotomy for this thing, upper esophageal sphincter release. Here again you have to make a muscular release, but that may not be enough in old age. Old age always rule out malignancy. They are also used to use this balloon to sometimes dilate in benign conditions. But in old people, don't think you can get away with it. It may be because of this either malignancy being there or because of the paraneoplastic effect, achalasia is happening. So coming to this malignancy in the oral cavity, I have come down to the esophagus, but I did not discuss the malignant process in the mouth. It's called epidermoid carcinoma. Epidermoid carcinoma simply means it's carcinoma arising with the epithelial tissue. That is the squamous cells there. So it's a squamous cell carcinoma, and the most common location is lower lip, tongue. So this is because this is very good prognosis. If you detect early enough, you can actually get a 100% cure. But if you get lymph node metastasis, the lymph node metastasis means the tumor has traveled to the lymph nodes because of they are not dealt with it initially. Then prognosis may not be as good. Even that can produce mortality. So that's about the thing. Then in the tongue, if it is the posterior part of the tongue, especially, even if you see what's called a white patch, leukoplakia in the posterior part of the tongue, be more careful because posterior part of the tongue malignancy is spread very fast. So that is something called pre-malignant lesion called leukoplakia. Leukoplakia means white plaque, white raised area, either in the mouth, wherever, tongue, buccal, other buccal mucosa. It's called leukoplakia. Sometimes it becomes red color. It's called erythroplakia. Sometimes it has got a warty appearance. It's called verrucous. Verrucous, it's all more likely to be malignant. Such lesions has to be biopsied. Always the proof of the pudding is in taking biopsy, seeing it, seeing the malignant cells there. So that's a cancer in there. But esophageal cancer, even if you get a biopsy result and all that, generally by the time you get that, it's beyond a cure. The cure is generally esophagectomy, that is a surgical removal of the esophagus. But most of the time you might expect the mediastinal lymph nodes, so it won't be much useful. So generally it's a palliation only by putting a tube or things like that. So the next part of the from esophagus we go to the stomach. The stomach has 3-4 parts are there. The stomach is not one it's a one organ, but it has 3-4 parts. The uppermost part is called cardia, because it's very close to the heart, cardia. The next part is called what's called fundus. Fundus means the bottom part actually, but that's the first above. The stomach is, if you can imagine it with the bottom up tube. So that's the fundus, and then that is a larger part called body. Then there's a dilated part, antrum. Antrum simply means a dilated cave-like thing, antrum. And then it's then narrows down to a small tube called pyorus. Then it becomes a larger tube called duodenum, because duodenum is called, duodenum also the part of the stomach, we can say. The duodenum is called duodenum because it is about 12 inches long. 12 finger, duodenum. Duo means 2 plus denum, that's a dasham. That is duodenum. And so all these things includes the stomach. And the stomach problems are in young people, you have what is called pyloric. I'm not describing all those things, pylorostenosis and all those things. But in old people, main problems are, one is called peptic ulcers, and then you have different problems in old age only. Volvulus of the stomach, the stomach rotates on itself, and then the blood supply will be cut off. Volvulus, there are 2 types. One is called the axial, that the vertical volvulus. So it actually cuts off the blood supply, acute condition. If you don't do a surgery immediately, patient will not survive. So that's always the stomach, common in old age. Not that common, but I've seen 2 cases. So it's not that uncommon either. It may be 1 in 10,000 or something like that. So it has to be kept in mind, old people. Young people, you don't think somebody has problem, pain in the upper part of the abdomen. You might not think, you might think it's some other problem. So, but volvulus you have to keep in mind in old people, volvulus. Then other problem is, I told you, the ulcer, peptic ulcer. It's a peptic ulcer can take place in the stomach. It's called gastric ulcer. It's duodenal ulcer. So after that, you can have what's called gastrointestinal upper gastric bleeding, stomach bleeding. The common cause of stomach bleeding is because of ulcers. Ulcer means a break in the epithelium, break in the lining of the stomach is called ulcer. The ulceration, people used to think that ulcers are caused by acid. Of course, stomach has a lot of acid. Its pH is pretty low. It's a very strong acid. pH is maybe around 3 or something. It's called hydrochloric acid. It can digest protein, definitely. But that's not what's causing the ulceration, because just as stomach has this acid is for protection from microbiome, and it is for all these things, aid in digestion and all those things. Digesting the protein and all those things. But the stomach itself gets protection from this acid by its own production of what's called prostaglandins, certain types of prostaglandins which gives it alkaline and neutralize the acid. So there are 2 ways peptic ulcers can come. One is the neutralizing ability of the stomach by the prostaglandin is inhibited by our therapeutic program. We give what's called NSAIDs for inflammation and pain. NSAIDs, non-steroidal anti-inflammatory drugs. That the drug which you get, even all the counter, sometimes you get Brufen, Mefta and all those things. They are actually what's called non-steroidal anti-inflammatory drugs, NSAIDs. And they are the culprits for reducing the prostaglandin secretion from this thing. prostaglandin which produce neutralize the acid. So when that happens, the acid will digest the stomach lining and produce ulcer. That's one way. Another way is, but the more important way is, by an organism called Helicobacter pylori, discovered not when I was a student, after that, by an Australian physician, and he actually experimented on himself to see that it produces ulcers. So these ulcers are acquired worldwide. It's almost endemic. No part of the world is free from it, and especially poor countries, poor socio-economic, poor this one crowding and all those things. Almost 100% people will have Helicobacter pylori infection. What is the pylori Helicobacter means? Like that, helix, like that. It's a gram-negative rod, I think. No, not gram-positive rod, I think. Produces is it will actually invade the stomach mucosa cells, all the cells. There are 3 types of cells in the stomach. One is called chief cells, which produces some some secretions and all those things. Some mucus also. The mucus cells itself produce a lot of mucus. There is something called the parietal cells. Parietal cells are the ones which produces acid. So it does not spare any of these cells. It invades all these cells, and it will produce the acid, would lead to what's called achlorhydria. It can chief cells, mucosal release of the mucosa, because that's again protection for the stomach. It's also reduced, and finally it will lead to this what's called gastritis. So actually there are 2 types. What's called gastritis and another is gastropathy. It's actually a pathologic spectrum. Gastropathy can lead to gastritis. Gastropathy simply means there is a lot of edema, inflammation, but no inflammatory cell invasion. When there is inflammatory cell invasion, like leukocytes, round cells, leukocyte means acute inflammation, round cell means chronic round cell inflammation. So when you have these cells are seen in pathologically, then you say it's gastritis. Otherwise, it's called gastropathy. So it's a spectrum. The NSAIDs usually produce gastropathy, but it can also produce what's called gastric erosions, small breaks in the gastric mucosa and produce bleeding. Gastric erosions. Then that's gastritis can lead to again gastropathy. Gastritis is to ulcers, peptic ulcers. So this is the most common cause of peptic ulcer. Peptic ulcer means the duodenal ulcer as well as stomach ulcer. The duodenal, the 12-inch length upper part of the stomach, duodenal ulcers are more common than the gastric ulcer. Duodenal ulcer produce pain. Gastric ulcers may not produce pain, but the more pathology is seen in gastric ulcers, because some of them can be malignant. Even H. pylori is a pre-malignant. I mean, it produces malignancy also. Invasion by H. pylori can produce malignancy also, carcinoma stomach. So, and the stomach ulcer can sometimes lead to bleeding. So, mortality in old people, bleeding can lead to mortality. So, it's a mortal disease, the stomach. Sometimes the thing is that, it may be asymptomatic. There may not be much pain. Only thing is, one fine day start bleeding. Or sometimes, the stomach ulcer will just perforate. Perforate means it just gives way. The stomach contents come out of the stomach into the peritoneal cavity, produce what's called peritonitis. So that's another fatal condition. And but the duodenal ulcer is more common. But in old age, stomach ulcers can lead to a lot of bleeding. There is one particular ulcer called Dieulafoy ulcer. The Dieulafoy ulcer means and also with a lot of bleeding. It's from one of the gastric arteries. Hmm? It used to be very mortal. Nowadays, you can endoscopically seal that artery, or sometimes you might have to do a surgery also. And that is the treatment for for when you have this thing H. pylori infection. H. pylori can be because H. pylori destroys the mucosa by the enzyme called urease. So if the urease is present, it can be seen in the serum urease or a breath test. You need not take a biopsy from that. But a biopsy you have to take to see the H. pylori. Sometimes if you don't see the H. pylori, you can do this test, urease test. If you proven H. pylori infection, you have to give what's called triple therapy. Triple therapy means you have to give an antibiotic, metronidazole, and a proton pumping inhibitor. Proton pumping inhibitor means acid suppression. Inhibitor for about 1 or 2 weeks to eradicate H. pylori infection. So so I have got through the gastrointestinal bleeding also. The bleeding is mostly caused by these things, but sometimes there's in old people they can have what's called giant ulcers. It may not heal very easily, but nowadays with the triple therapy it heals. It's that olden days the high mortality was because of the giant ulcers. Stomach. Then this one even duodenal giant ulcer. Giant ulcer means it's more than 2 centimeters, 3 centimeters in dimension. Then this one I told about it. There's another called geriatric ulcer. Geriatric ulcer is in the cardia of the stomach. It's peculiar because it does not produce pain in the stomach. It produces pain in the back and this one sternum and all the space. It misleads you to think that the person has got a cardiac problem. No, not that. But that's why importance of endoscopy. You get a specialist to do an endoscopy. If you cannot do it, get a specialist to get an endoscopy. Get a gastroenterologist or an ENT specialist or some surgeon who does this commonly, and do this thing and find out whether the stomach ulcer. 50% of the ulcers are without symptoms. So there is, if you doubt anything, so like he has got small bleeding, and always do if you've got melena, do dark colored stools. Need not have hematemesis, melena also, small bleeding. You have to do always rule out malignancy in the stomach, not because the stomach malignancy is curable. It's not curable most of the time, because by the time you diagnose it, it is spread. And it is one of the tumors which is very bad prognosis, just like esophagus. Esophagus also, by the time you diagnose, it's spread throughout the body, not throughout the body. If not throughout the body, that part, mediastinum, lungs, and all those things. So it's not curable, and but it's palliation mainly. I told you about the volvulus in the stomach. There is, people can also have what's called dyspepsia. I don't know what it means actually. Dyspepsia can refer to any number of things. But generally, it is best to avoid that dyspepsia. But non-ulcer dyspepsia described, I don't know. But I think it's a blotting sensation or something, ulcer-like symptoms, but without an ulcer. It's actually a post-endoscopy diagnosis. Non-ulcer dyspepsia. I'm sorry, throat is bad. I think that's about all. Most of the things I have covered in this thing, in the short talk, and regarding stomach, regarding esophagus, or oropharynx, and mouth, and always ask me some questions through your the YouTube questionnaire. I'll be happy to answer your questions, because I read 2-3 times this particular topic, go through the net and all those things, collect some data. It will be useful to you also. It is useful to me at first. That's why I'm doing it. Thank you very much.